Amo, take it away.
Good afternoon, everyone. We've talked about more stroke, had lunch. We're kind of tired, and this is the perfect time to talk about delirium, right? All right. Get going here. So the objectives of this talk are define delirium, separate it from other causes, review the importance of early detection of ICU delirium, as well as prevention and management, identify and review validated delirium assessment tools, and hopefully incorporate them in our care, identify modifiable and non-modifiable causes of delirium, and then apply multifactorial non-pharmacological strategies to prevent, reduce, and manage delirium burden in our critically ill patients. And then we'll touch a little bit on the limited role of medications in delirium management. So what is delirium? The National Institute of Health defines it as sudden severe confusion and rapid changes in brain function that occurs with physical or mental illness. There are 4 domains to look for in a patient who's acutely delirious. It's usually the disturbance in consciousness, change in cognition. There's always periods of fluctuation, whether a little bit more lucid in the morning, a little bit more confused later during the day. And then there should be also some HNP or lab documentation showing the cause, the physiological consequence of, or a general medical condition that could be causing them to have this delirium. For this, the purpose of this discussion, we'll talk mainly about ICU delirium. So many terms out there that are often thrown around in the ICU. Sometimes correct, but sometimes they lead us a little bit off, astray in how we manage these patients. These include ICU psychosis, acute confusional state, sundowning, altered mental status, toxic or metabolic encephalopathy, acute brain syndrome, ICU syndrome, just to name a few, but there's so many. Now, dementia is a very well-known risk factor for delirium, and I focused on the slide on dementia because it's really important to differentiate between a patient who has dementia versus someone who's actually acutely having delirium. And also a patient who has dementia can have a delirium also, and so you should be able to, kind of figure out how to treat them. I'll just highlight a few because this is a little bit of a busy slide. In delirium, the patient is, there's impaired function of neurons, which is not the case in dementia. And then like we talked about a little bit, there's waxing and waning of symptoms. A patient with dementia develops symptoms over time and progressively worsens cognitively. EEG findings are usually show a slowing in delirium. However, in dementia at baseline, they can be normal unless the patient really has advanced disease. And then recovery in delirium is good if treated on time, technically reversible, but you can't, in dementia, these patients usually worsen over time and you can't reverse the symptoms. Okay, the clicker. Okay, signs and symptoms, just briefly. These patients usually have cloudiness of consciousness, disorientation, inattention, illusions, they're confused, climbing out of bed, hallucinations, fluctuations of consciousness like we talked about a little bit. Some have just depressive state, like flat affect, apathy, they're withdrawn, they're not participating in any activities. And then other neurological symptoms that have been associated include some dysphagia, tremors, motor abnormalities. Delirium is classified as either hyperactive, hypoactive, or mixed. In a hyperactive patient, it's self-explanatory. They are anxious, restless. Those are the ones pulling out everything in the ICU. Rapid emotional changes, hallucinations, etc. In hyperactive states, they have a flat affect, they're withdrawn, apathy, they're sleepier than usual, they're not participating in any of the activities, and you can have a mixture of both. And believe it or not, in ICU, you mostly see hypoactive and mixed states. And because of that, delirium often goes undiagnosed and untreated, but has long-term effects on these patients. Epidemiology, up to 30% of hospitalized patients have been reported to develop delirium. The statistics are even higher for ICU and mechanically ventilated patients, up to 80%. I mean, that's pretty big. Most literature investigated so far doesn't really cover neuro ICU patients, but it's really extrapolated from general ICU. And despite high delirium prevalence in ICU settings, it is frequently unrecognized and misdiagnosed. Symptoms may incorrectly be attributed to dementia, like I mentioned earlier, depression, or ICU syndrome, which is basically considered to be an expected inconsequential complication of critical illness. Duration is about plus or more than 2 days in the ICU, and the duration of symptoms are usually short-lived if risk factors are identified and treated or avoided in the first place, or patients can have long-term cognitive problems up to years. So impact of delirium, it's associated with increased burden of illness, higher morbidity, mortality, increased ICU length, hospital length of stay, and increased suffering, obviously. Up to 5 extra mechanical ventilation days just because of delirium, about 8 to 10 extra days of hospitalization, and on average, $15,000 per patient who's hospitalized with delirium, just added by the fact that they have delirium. Studies have found a strong correlation between delirium and long-term cognitive function, which I did mention that. About 50% of the patients who actually experience ICU delirium have a cognitive impairment at discharge. 1 in 3 suffer long-term effects, and then impairment has been detected in multiple patients at 3 months, 12 months after being discharged from the ICU. And if you want to put it in dollars, so it makes more sense to all of us sometimes, $4 to $16 billion cost in the US alone per annum in mechanically ventilated delirious patients alone. So it's much more than that. Now, this is a busy slide showing the many causes of, the many pathways that are associated with delirium. First of all, pathophysiology of delirium is poorly understood. However, if you look at this slide, you can kind of see some of the hypothesis of what's causing it. The main ones are inflammatory changes, reversible impairment of cerebral oxidative metabolism, and multiple neurotransmitter abnormalities. And this is another busy slide that just really goes a little bit further into what we just talked about. So one of the hypotheses believes that delirium is a neurobehavioral manifestation of imbalances in the synthesis, release, and inactivation of neurotransmitters, namely dopamine and acetylcholine. leading to instability and unpredictable neurotransmission and hence delirium. And then inflammation, as we all know, in critical care illness, patients have multiple organ dysfunction and production of inflammatory mediators, and these lead to endothelial damage, thrombin formation, microvascular compromise. And studies in animal models have even shown that these mediators cross the blood-brain barrier, and as a result, those animals were found to have EEG patterns that are similar to patients who have delirium due to sepsis. And cerebral oxidative metabolism is also found to be another cause. So we have modifiable and non-modifiable risk factors of delirium. So we'll go over the non-modifiables first, and then we'll go into the modifiable ones, because those are easy. Those would be the ones to focus on to treat these patients. So non-modifiable, we have age, dementia, baseline cognitive impairment, apolipoprotein E4, which is also a risk factor for Alzheimer's, depression, comorbidities, severity of illness, hearing impairment, visual impairment, although you could argue that you could use some hearing aids and help those patients too. Surgery, alcohol use, and drug use. Before hospitalization, obviously. Now, modifiable, we have medications, more especially sedatives and analgesics that we administer, mechanical ventilation and procedures, room changes, visual hearing aids, pain, electrolyte imbalances, metabolic imbalance, disturbance, immobility, restraints, catheters, nutrition, hydration, lack of, that is, and I included the infamous Q1 neurochecks. So diagnosis is really there's 3 ways of diagnosing or identifying patients who have delirium. And it's really important that we use validated tools so we're consistent and able to actually catch it on time and treat it. The first one is the DSM-4, which is really for psychiatrists. But which one of us actually has the luxury of having a psychiatrist on staff all the time to do that for us? So there is the CAM-ICU, which is the confusion assessment method for ICU assessment, which is great and has been reproduced and used multiple times, and the intensive care delirium screening checklist. Before we go further into those, I just wanted to introduce also the scale that all of you are familiar with, which is the RUS score, because it's always very important also to assess the sedation scale for these patients. And it's also good to set a goal for how much sedation we're going to give these patients so we can continue to be able to assess and avoid delirium in treating them. So this is the CAM-ICU, which is really easy to administer. Most of the time you can do this in 5 minutes. The first thing to assess is acute change or fluctuation. Is their mental status changed from their baseline? You ask family, they'll immediately tell you, or you've seen them at admission, this is your subsequent evaluation, and then you know. Or has the patient fluctuated in the last 24 hours? And then if that's a yes, you go on to step 2. If that's a no, then they don't have any delirium. So then you assess their inattention. You ask them to squeeze your hand when you say the letter A, and you say you spell out one of those words. And then more than 2 errors, they probably have delirium. No errors, you go to the RUS. If they're calm, meaning calm and alert, which is a RUS of 0, then you go on to assessing number 4. But if they're not, then they're probably, if there are any RUS other than 0, then they have delirium. So it's really easy to go through. We won't go through the ICD-SC because it's really busy too. But just so you know, there's 8 measures that you're looking for: altered level of consciousness, inattention, disorientation, hallucinations, psychomotor, agitation, inappropriate speech or mood, and sleep, wake, and then symptom fluctuation. The total score is 8. You get a 4. Chances are your patient has delirium, and you move on from screening them. So if we do it frequently, it shouldn't take time because then you get familiar with it. It's always important to understand the relationship between delirium, pain, and agitation. This is another busy slide, but as you can see, it depicts things that cause pain, delirium, agitation, and they all kind of feed into each other. In order to adequately manage delirium, clinicians need to also investigate and manage. Oh, I repeated that. Most patients who were in the ICU after discharge, when you interview them, they report being in pain, and that has to be really terrible when they can't speak for themselves, or they're on a ventilator. Patients who are intubated or unable to speak can be evaluated too. There's several tools out there for assessing a patient for pain. Here's one of them, the critical care pain assessment tool, which really goes by facial expressions, body movements, the vocalization, if they can, or compliance with the ventilator, muscle tensions, things that we all see in the ICU. If you're in the ICU, that probably show the patient is in some sort of discomfort or pain. So prevention is really important, since studies have shown that patients with delirium have higher mortality. Each additional day of delirium is associated with increased risk for dying. And actually, according to the SCCM, there's 3-fold mortality in patients with delirium at 3 months. And also, this was a really good study, even though it's a really small study. It had 102 patients that showed that reducing rapidly reversing delirium leads to outcomes that are similar to someone who never had delirium in the first place. So they actually had enrolled 102 patients. Delirium was reversed within 2 hours in 12% of the patients, and it persisted in 77% of the patients. The 12% didn't have any adverse effects from the delirium at discharge. And a little bit of a talk here about medications that have been tried to see if we could reduce delirium, like length of stay, or reduce coma-free days, or just medical management in reducing delirium. One study by Page and colleagues is named The Efficacy of Intravenous Haloperidol on Duration of Delirium and Coma in Critically Ill Patients, the HOPE ICU study. It was a randomized placebo-controlled trial with 142 patients. In that study, haloperidol did not improve mortality or the number of delirium or coma-free days. So there was an increased incidence of, however, there was an increased incidence of sedation and QTC prolongation in the patients that were receiving haldol. So just so haldol is not really recommended for these patients. And there's several studies that have been done that followed suit. And then another study done by Gerard and others studied haloperidol and ziprasidone for treatment of delirium in critical care illness. 1,100 patients were enrolled. 566 did develop delirium. And out of those 566, 89% were hypoactive, 11% were hyperactive. 184 were in the placebo group, 192 in the haloperidol, and 190 in the ziprasidone. The median exposure of the drug was about 4 days. The median number of days alive without a coma were 8.5 in the placebo, 7.9 in haloperidol, and 8.7 in zypresidone. So no significant between group differences in that study too. The SCCM does suggest using Precedex, because I can't say that word, for delirium in mechanically ventilated patients where agitation may preclude weaning the patient because they're so agitated that you can't really manage them. There was one randomized control trial done, no ventilator, no significant ventilator-free days or improvement in length of stay with the Precedex as well. But at least it helps you wean the patient off the ventilator without having them thrashing all over the place, was the point of that study. And then a study done by Perry Hunt, I can say that name too, Dr. P and colleagues had 192 mechanically ventilated patients. In this study, there was an independent and dose-related temporal association between receiving lorazepam and transitioning to delirium, as depicted on that graph. Low doses of delirium over a short period of time on those patients, they were not that susceptible to developing delirium. But really, when you get to giving the patient 20 milligrams a day of delirium, those patients were 100% likely to have to be delirious. So now that we've looked at, so the recommendation before we get to the slide, the recommendations from the PHARMACOLOGICAL guidelines are that there is no benefit for using any pharmacological protocol for treatment of delirium. Which brings us to the reason why we really have to find the non-pharmacological strategies to treat these patients. So studies have shown that prevention and management of delirium requires interdisciplinary approach with the goal of preventing and managing modifiable risk factors, as delirium is usually caused by multiple factors, obviously. The PHARMACOLOGICAL guidelines recommend the multi-component non-pharmacological intervention that is focused on but not limited to modifiable risk factors for delirium, reducing the risk factors, and then improving cognition, optimizing sleep. Again, optimizing sleep, that's a big one for me. Mobility, hearing, and vision, and optimizing like mobility, hearing, vision in critically ill patients. There was a study that was thoroughly conducted and validated by the SCCM. It's called the ABCDEF bundle, which is recommended, and it's the Awakening Breathing Coordination, Delirium Monitoring, Management, and Early Exercise Mobility bundle as a strategy of interprofessional evidence-based multi-compartment ICU management strategy aimed at reducing sedation exposure, duration of mechanical ventilation, as well as ICU acquired delirium and weakness. So it's a really good bundle to institute and use in your patients who are at risk or have delirium. When it comes to medications, less is really more. So we have to go through our patient's list of medications and avoid polypharmacy, explore medication withdrawal as a cause for why they're delirious in the first place, avoid anticholinergics, avoid benzos, minimize use of sleep medications, use the lowest necessary amount of corticosteroids, opioids. If it occurs for us, mostly with the patient who's on Keppra, switch them to another anti-epileptic. Change medications like famotidine to a PPI. check serum medication levels, check for dehydration, electrolyte abnormalities, reassess need for discontinued antibiotics. Less is more, do it daily, and try to eliminate these problems before they arise. So the main things in managing these patients is identifying and removing risk factors. Nutrition, hydration, constipation. How many times have we had a patient who's thrashing and throwing themselves all over only to find out that they were retaining urine? Many, many times. So promote sleep. Studies show that ICU patients sleep on average between 2 to 8 hours a day. Most of us, even healthy, cannot survive on 2 hours a day. So, and this sleep is mostly during the day. It's interrupted. It's really not quality sleep. So we need to turn off alarms, lights, beepers at night. Decrease the amount of time that we wake up the patient unless it's necessary. Manage pain, anxiety, ventilator desynchrony, reduce the amount of time we do neurochecks when we're able to do so. Most of our patients are usually not even watching television, but you will see the television on as you pass by, and it's 2 o'clock in the morning, and they're delirious. So it's just things to be mindful of. Noise control, quiet time, consider earplugs for those who can tolerate them, promote comfort, reorient the patient as often as possible during the day, have a protocol that we can use and follow to make sure that each and every patient gets reoriented. Allow for family interaction during the day, cognitive stimulation, games during the day, music that they usually listen to, rehabilitation. So the easy way to make sure that's done consistently is to use, as I already mentioned, some sort of bundle. And like I said, the ABCDEF bundle is really great. It encompasses a lot of things. So we'll go over some of the literature that was done just to show how effective to show the efficacy of this tool. The PADIS, the SCCM literature reviewed 5 studies. One was randomized control trial, and the other 4 were before and after studies that found that non-pharmacological multi-component approach to delirium reduced delirium significantly and decreased ICU duration, delirium days, length of ICU stay, and hospital mortality. And then in a study done by Daly and colleagues in 2017 called the Improving Hospital Survival and Reducing Brain Dysfunction at 7 California community hospitals, implementing the PAD guidelines via the ABCDEF bundle in 6,000 patients, they found that increased bundle compliance was independently associated with improved survival and more delirium and coma-free days after adjusting for age, severity of illness, and presence of mechanical ventilation. So we can do this. We can all even imagine a calm ICU where none of our patients are delirious. They are easy to wean off mechanical ventilation and overall have less length of stay in the ICU and hospital and less morbidity and mortality. So we just have to flex the muscle. We can all incorporate the ABCDEF bundle. This slide just gives you an overview of how to approach these patients. Obviously, you want to have a protocolized way that we assess these patients at admission and also every day. High-risk patients, delirious patients, obviously we start, doing all the below. treat the modifiable risk factors, target no sedation or light sedation, avoid benzos, early mobilization, pain assessment and management, try to optimize their sleep, schedule reorientation, encourage visitors, all the right things that could help them. For non-delirious patients, we have to keep reassessing them and also figure out which ones are lower risk and which ones are high risk and follow one of those tracks. I'm out of time, so I'm going to go quickly here. So this is the ABCDEF bundle. The first part, A, is really, I can go back here. I have more of an explanation for A here, which is pain management. You assess, prevent, and manage pain. And this is how you do it. The clicker got me there. Okay. So you perform routine pain assessments. Patients who, you make sure that all the patients are assessed, including those that can't verbalize their pain. You use your BPS scores, you use your COP, you use other behavioral measures, treat pain and procedures, painful procedures preemptively before, the patient actually is in a lot of pain. Give boluses rather than IVs. So minimize light sedation is the key. And then you manage their agitation and sedation. Use a protocol that everybody follows. That way, we can know exactly what we're doing. Identify underlying reasons for agitation. Perform daily sedation interruptions and avoid sedation-induced coma, avoid benzos again there, and medications. And then on the BCDEF part of things, you also incorporate that into the first portion. So if you look, the next thing is B, which is spontaneous awakening trials and spontaneous breathing trials. So you wake up, you wake your patients up in the morning, you turn off their sedation, and then you put them on some pressure support. You allow them to take their own breaths, and then you incorporate that with exercise, reorientations. This can be done even on mechanically ventilated patients. Perform early mobilization. I mean, several studies have been done. I think we all know on that end that, early mobilization really helps. What's the point of saving our patients' lives and then they don't really have a great, functional outcome in the end? And then we talked about choice of sedation, using a validated tool to assess the patient daily, and then family engagement. They can play games with the patient. They can, read with the patient, help us with keeping, them cognitively challenged. So there is barriers and, there's facilitating factors and barriers when it comes to implementing a new bundle, just because for some reason now I'm selling this bundle. However, it's good to just know that you have to implement certain things to make sure it goes well if we're going to be serious about making sure that our patients don't have delirium. Daily interdisciplinary rounds are great. Key implementation leaders who come in and see where we are and what needs, education gaps and fill those. Sustained efforts, understanding the bundle's quality and strength. Barriers are usually things like fear of adverse effects. Obviously, we worry about these patients falling. They have they have catheters, they have ventilators and things that could cause that. Communication challenges, knowledge deficits, workload burden. In summary, delirium is associated with poor outcomes, and it's worse with increased duration of delirium. We have to assess our patients at admission and daily, address modifiable risk factors, use multi-component strategies, and protocolize care towards managing our patients, and avoid benzos, use sedation judiciously, and keep our patients delirium-free. Thank you.